flash drive. Input
You can start.
Right. Welcome, everyone. I'm going to wait just one more minute to let people kind of filter in from the waiting room. But if you're on right now, thank you for joining us on Spine Time webinars. We're going to be talking about high-tech spine today. So just in 30 seconds, we'll get started. All right. Good evening. So welcome to the Spine Time webinars. Thank you for joining us on this Wednesday evening. If this is your first time on one of our webinars, please use the chat window to enter your questions. I'll be moderating that and making sure our guest speakers try to get to those questions as soon as possible. So today's topic is on high-tech spine surgery, how navigation, robotics, and augmented reality can help with your spine care and your surgery. Just a little bit about us. So we are the Weill Cornell Center for Comprehensive Spine Care, where we really pride ourselves on an integrative and comprehensive approach, utilizing neurology, spine surgery, pain management, rehabilitation, physical therapy, mindfulness, complementary medicine, all different modalities to really optimize the patient experience, figure out the diagnosis, and then most importantly, get the patients to functioning and living their fullest life possible. So today I'm very excited to introduce the guests of the show. First, I'm sure most of you know Dr. Roger Hartl. He is the director of the Comprehensive Spine Center, professor of neurological surgery, and the chief of spine surgery here at the hospital. And our co-host today is Dr. Lynn McGrath, assistant professor of neurological surgery, spending most of the time, I think, at NYP Queens, where we have built a part of our spine center outreach. So thank you to both of our guests for joining us. And I'm excited to listen to what you guys have to say. So Dr. Hartl, I'll pass it over to you.
All right, well, Ricky, thank you so much. Dr. Singh, thank you for this really nice introduction. And yeah, I mean, we're all sitting here in the Spine Center and dealing with the things that we like to do most, namely help patients using technology. But the most important thing is obviously always that you got to do the right intervention for the right purpose and for the right patient, right? And I just want to put it out there because we're talking about high-tech surgery. The thing that certainly should come first is obviously the diagnosis, and then you got to figure out, well, is this really a surgical indication? And if it is surgical, obviously we want to do it the least invasive way, the safest way, the most efficient way, and frequently it is technology then that helps us achieve that goal. Jokingly, I always say that the least invasive operation is the one that you don't do because the patient doesn't need it, because so many times do we see patients who are being sent to us who had some kind of procedure done, and you're wondering, and they're worse than they were before. So you're always wondering, why was this done in the first place? But the idea behind the comprehensive spine center is then to make sure that this doesn't happen, that we work up patients properly and then come up with a proper diagnosis and then the right treatment. When it comes to surgery, though, minimally invasive surgery is frequently a good option because the idea is to minimize the access. And that's not necessarily only the small incision that's important, but it's also the amount of injury that you have to take into consideration when you go in there surgically and you're trying to approach the surgical target, and then you typically have to remove it or you have to stabilize part of the spine. The idea is really to minimize the injury to all the tissues that you encounter on the way, that may be muscle, tendon, bone, because if you minimize the injury to those tissues, those patients will have less pain post-operatively, and this is nicely depicted here in this illustration. So there's less soft tissue damage, less blood loss, less scarring, less pain, and hopefully patients then go home earlier. or they may not even have to be admitted in the hospital. More and more surgeries now are being done ambulatory, and then they just go home and can hopefully go back to their normal activities earlier. Now, here's a nice little thing that we worked on for last years. Dr. Singh, myself, Dr. McGrath, and many other surgeons here in the spine group, but really surgeons from all over the world. This is a book that just came out last week. It's for the spine surgery community, of course, and it summarizes everything that we know about minimally invasive spine surgery. This was put together by myself and Dr. Navarro, who's currently one of our spine fellows, who's going to move on to take a job in Florida, actually, in a few months. But I'm really excited about this book because a lot of the things that we're going to talk about today I actually summarized in this book. And this picture on the title page kind of summarizes. We put this, we were trying to figure out, well, how can we show everything that we do that's minimally invasive in one picture? And we came up with this picture, and in this image, really, you see all the different technologies, the high tech that comes into spine surgery, from navigation, augmented reality, tubular, operating through a little tube, operating through the endoscope, stabilizing the spine, putting in cages that's illustrated in this picture, and more. So, for most of you, this book will not be that relevant, of course, unless you have you want to pursue a career in spine surgery yourself as a surgeon. But this is just one of those things that we're really proud of here in the Spine Center, because we call it jokingly the MIS Bible, but I really think that this is the most comprehensive book in minimally invasive spine surgery. But I want to hand it over to maybe Lynn, and maybe Dr. McGrath wants to say a few things about his experience with minimally invasive spine surgery.
Yeah, thanks, Dr. Hartl. And that book, I'm sure will become the MIS Bible. I think actually on some of the slides, we've got pictures that were on the cover of that book because they're such, representative pictures of the type of things that we can do these days. This is kind of the most visceral representation of the difference between the way that spine surgery used to be done and the way that we can do spine surgery now. What used to require a big open incision can oftentimes now be done through a small tube, like the one you see on the left. And this is what it looks like in the OR. I think it helps for patients to see what we're actually doing and what it means to actually do surgeries through tubes. And you can see in this sequence of pictures, we're just making a small incision and we're inserting a series of expanding tubes in order to dilate our way through the muscle, keeping it nice and healthy down to where we want to operate, rather than having to do a big incision to kind of see all of the anatomy. We can look through the tube in order to disrupt the least amount of tissue possible. You can also see here, you can go on, you can also see here that we have the ability to navigate. So this is like GPS for the spine, and it allows us to bring the tube and minimally invasive techniques to more and more kinds of surgeries. So in this kind of a technique, we take a CT scan while the patient is in the OR, and we register that. It means we match it up to the patient's own anatomy, and then we match that image up to all of our instruments. And so we can see with the computer where our instruments are in 3D space in relation to the patient's anatomy. And it's a long explanation, but what it means is that we can make much smaller incisions so that we don't have to actually see all the things that we're operating on. We can see through the skin, through the tissues, and use the navigation system to put screws in, to put rods in, to take discs out, to do laminectomies and take the pressure off nerves, all through these very small incisions where we keep as much of the normal tissue intact as is possible. This is what it looks like to put a screw in if we're doing a fusion surgery. It doesn't require a big incision anymore. We can use the computer and this GPS system of 3D navigation to even do things like a fusion through very small incisions and disrupt as little of the normal tissue as possible. And I keep saying that, and the reason why that's important is because the more of the normal tissue that you disrupt, the more chances you have of having pain that continues after surgery, the more chance you have of needing another spine surgery at some point down the road in your lifetime. So, we talk about getting out of the hospital sooner and having smaller incisions that are less painful and easier to recover from, but there's also long-term benefits in that it minimizes the chances that the patient's going to need another surgery down the road. This is is this a video or a picture, Ricky?
Just a video. I mean, just a picture.
A picture. This is just an example of one of the robot arms that we use. So now we can use a robot arm and plan out before we even enter the OR. We can plan out what the ideal trajectory for some of the screws and the rods and the cuts in the bone that we need to make happens to be while we're sitting in front of a computer, and then we can have the robot help us do all those different steps perfectly through the smallest incisions possible. This is what it looks like for the surgeon to be putting in screws while in the OR. This is what it looks like in the 3D navigation, the GPS system. You can see the screw going further and further into the bone in just the right spot. And that's what we're looking at during the case to kind of guide us. And again, this is just another demonstration of what used to be required in terms of a big incision where we visualize directly all of the anatomy. We need to see all the bone and all of the different tissues in order to be able to know exactly where we are and to cut the right things and to decompress the nerves in just the right places. Now with navigation and now with these tubes, we can get the same effect, if not a better effect, but with a much smaller incision and just going through a little tube like that. This is a picture of an example of the kind of a fusion surgery that you can do through a tube with very small incisions. And I think the next slide shows, what kind of incision you're left with after what previously would have been considered a major fusion operation. Now we have the same thing possible through these two very small incisions that are very easy to heal and recover from, and make it easier to get back to work, get back to your activities of daily living. Life as you knew it suddenly is much easier to get back to. Augmented reality is something that we have been using a lot in the OR recently, and it is just another step in the same direction, another tool that we can use to do things more accurately with less time and to extend these minimally invasive techniques to more and more types of surgeries. This is just an example of what it looks like in the operating room. There's actually, I think, Dr. Hartl, and he's got the operating microscope. We do all these surgeries through a microscope because it's microsurgery, and it allows us to be as precise as possible. And you can see on the screens to the left and the right of Dr. Hartl, there's an image of the surgical field, and it's got a little bit of an overlay where you see this pink, it looks like a drawing over what we're actually seeing through the microscope. And this is a technology that allows us to pick out important structures or to make a plan on the computer before we even do surgery, and then visualize that plan through the microscope superimposed on what we're seeing. So if we decide we want to make just the right cut through a certain bone, we can make that plan ahead of time and then through the microscope see on that bone where we had planned the cut before surgery. Or if we want to put a screw in just the right place, we can plan that ahead of time, and then looking through the microscope, we can see exactly where we had planned that screw to go beforehand. And so we know what that perfect trajectory will be while we're in the OR.
Let me ask you guys a question. Presumably, minimally invasive spine surgery wasn't embraced initially. Probably took some time for surgeons who were trained in more of the open manner to kind of embrace this technology. When a person or a patient has been told that they need spine surgery, how important is it for them to ask their spine surgeon if they practice minimally invasive? Is this the gold standard now? And if you're not practicing minimally invasive, are you not staying up to date with technology?
Dr. Singh, this is really important, right? because just because somebody has minimally invasive on their business card, or it says, on the website, it doesn't mean that that's necessarily the better surgery. It really depends on, obviously, the surgeon, the experience, the training level, who they trained with, and we had a spine time webinar that about that topic, a while back. How can you pick the right surgeon for your operation? And it's a really difficult question. Obviously, minimally invasive surgery, high-tech surgery, that's all great, that's all important, but it has to be used for the right reason and the right context. And then technically it has to be done perfectly well. So I think patients should certainly look at that. I think at the end of the day, it's still important that the surgeon that you're picking, though, has experience, has a good reputation. You can ask them, how many other surgeons do they operate on? How many doctors do they take care of? I mean, those are usually kind of indicators of how good somebody is. But it is also important to pick someone who is familiar with latest technology. When I started to, when I made the decision to go into spine surgery, there was none of this stuff available. Augmented reality wasn't available, navigation wasn't available. And I was very worried because I love brain surgery, and I liked using the microscope, and navigation was just coming out. And when I started going into spine surgery, I was worried because I thought, I'm never going to use the microscope again. I'm never going to use navigation again, because spine surgery at the time just didn't really utilize those technological achievements. And now the truth is, 10, 15, 20 years later, that I use the microscope, and Lynn used the microscope more and navigation more than most of our colleagues who do brain surgery. So just as an example, because there's a question in the chat box, how much has changed over the last 10 years? There has been a tremendous evolution in spine surgery. Technology, augmented reality, navigation, all these things that Dr. McGrath mentioned. This is all stuff that came up over the last 10, 15 years. So it is important, obviously, to utilize it, but don't get blindsided by advertising that high tech alone or minimally invasive alone is not everything.
How does while I get the slides up again, patients might be reluctant to kind of question their surgeon's experience. How do patients ask you without insulting you? How many have you done? Do you operate on surgeons? What kind of questions have you gotten that you welcome instead of kind of get turned off by?
Yeah, I mean, that's a difficult question to ask, of course, for a patient. And it's also a difficult question to answer for the surgeon without sounding arrogant or, so it is a fine line. It's difficult. Now, I don't have the best answer for that. A lot of it is reputation. I mean, already, before you even see a surgeon as a patient, you do your research, so already, and you talk to colleagues, right? And I think that's a lot of it. And then obviously, if you ask the surgeon and the surgeon gets insulted, that's usually a bad sign also. So you should take that into consideration.
I was going to say, if your surgeon gets insulted, if they get asked what their experience is like, then it's probably not the right surgeon.
Yeah.
While minimally invasive and robotics and all this stuff certainly sounds exciting, and I'm from the rehab side of it, I do see patients recover much faster because the muscles have been spared, so you don't have to make such a big incision. Presumably, you still need to have the skills to do a fully open surgery. How often do you have to convert from one of these minimally invasive options to an open option once you get in there and you're kind of seeing things with the microscope?
Very rare. But it is, we had a spine time webinar about the work that we do in Tanzania, for example. So we do surgeries in Tanzania, spine surgeries, and there you obviously they don't have a lot of these high tech possibilities. So there you have to do a lot of these surgeries the way that we used to do it here maybe 10, 20 years ago. And it is, I can tell you, it is sometimes a challenge. I mean, we're so used to doing everything minimally invasive that having to go back and then suddenly you have to do it the old way can be very frustrating,
Yeah.
So.
There's a question in the chat, and I'm not sure, it might be beyond the scope of this webinar, but specifically about something called Vertiflex, which is a minimally invasive spine treatment. It's not, technically something that our surgeons do, but I'll let you guys answer that. What do you know about Vertiflex as a procedure, and is this something you support, encourage, or recommend other treatments?
Yeah, I'm not that familiar with it. Dr. McGrath, maybe. I know these devices, we use them typically in patients who are not good candidates for more conventional minimally invasive surgery. It's a minimally invasive device. It's a great idea because it could theoretically achieve some decompression of the nerve structures in the lumbar spine, but it's not as efficient as a minimally invasive decompression, like Dr. McGrath is going to talk about endoscopic surgery, for example. I do this through a tubular retractor. Compared to those, the Vertiflex may not be as efficient, but it has other advantages, meaning that you can do it under local anesthesia, and it's very, very safe.
Dr. McGrath, you want to comment on endoscopic spine?
Endoscopic spine is basically just an extension of what we've been talking about in terms of the goal of minimally invasive surgery and all the technology that Dr. Hartl has worked to pioneer and perfect in the operating room is all designed around the idea of seeing the anatomy better, being more precise with what we're doing, and leaving as little trace that we were there in the operating room as possible. And so the endoscope is just another tool in the toolkit to do the same thing that we've been talking about, to be able to go in and clean out the area around nerves or take out a disc herniation, and it's just through an ever smaller incision. This is through usually a 7mm port, and it's basically just a single port. We stick a camera through, and there's a little working channel that we can put tools through in order to work on the spine. And the goal is just, once again, taking the whole concept of leaving as much normal tissue behind and disrupting as little of the normal anatomy as possible while getting the same effect. And so this is just kind of another tool in the tool bag. I think you can go to the next.
What are some of the most common indications for which you recommend or perform minimally invasive options? Things that we see a lot are disc herniations causing something like sciatica, right? Shooting pain down the leg, or spinal stenosis. What are the most common conditions you see for MIS? And also, are there certain diagnoses that are not amenable to MIS that do require an open surgery?
Yeah, I think exactly what you said. The most common things, the bread and butter cases, are the ones that typically are the most amenable to MIS surgery. So disc herniations or lumbar stenosis, basically arthritis of the lower back or of the neck, where you have overgrowth of the joints and it's causing pressure on one nerve or another, and that's causing trouble walking or pain going down the leg. Those types of things tend to be the most amenable to minimally invasive spine surgery, which I think is why it's such a great tool, because most patients have these common problems that are very amenable to minimally invasive spine surgery. Of course, there are always going to be things, large tumors or trauma, spine fractures, scoliosis or congenital deformities, where someone is born with a particular problem with the spine, the curvature not being correct. There are always going to be things that are going to require larger surgeries, but even those surgeries that do require a lot of tissue disruption and a big incision, they are still learning ways of doing things better through this minimally invasive philosophy. And we're trying to do everything now, even tumors. I think there's a couple slides on tumors there that we're now doing either through tubes or at least keeping in mind some of these minimally invasive principles, where we're using the microscope and navigation for all surgeries to try to do everything a little bit more accurately with a little bit less tissue disruption and a little bit less of a chance of having to go back to the OR at some point in the future. So There'll always be a role for large, kind of more traditionally invasive surgery, but even that kind of surgery is getting better as a result of all the tools that we've developed to be able to do minimally invasive spine surgery.
Patients sometimes come in and ask, and I don't see these ads or commercials much anymore, about something called Laser Spine Institute or Laser Spine. There used to be an ad with this lady with a small little Band-Aid in her back. What is that, Dr. Hartl? What is laser spine? Do we do laser spine? Is that a real thing? And how do you kind of answer that question when patients ask about it?
Yeah, I mean, laser spine, was a very, very big thing. Years ago, the Laser Spine Institute, they closed down, as you know, because they had a lot of problems. And just yesterday, we had a conference, a spine conference, where where one case was presented to us who had surgery there, and the surgery that was done there, you could clearly see was not really the right surgery. And as you know, and I don't want to, they don't exist anymore, so I can say these things. I mean, there were a lot of problems over the years with surgeries being done, not always for the right reason, probably. It goes back to what I said initially, right? You have to have the right indication for the right surgery. So that was, and the laser is always something that sounds really cool and exciting. And we use lasers for certain type of spine surgeries. We actually use lasers. But for the most part, I think it's not something that we routinely really have to take advantage of, because it's just not necessary. But it's certainly a great tool for certain operations. I was going to say something about what Dr. McGrath said about minimally invasive. And we actually, in our book, in the MIS Bible that I mentioned originally, there's a whole chapter about the indications for minimally invasive spine surgery. And based on the numbers, there are about 1.5 million spine surgeries being done in North America every year, a huge number. About half of those are being done with instrumentation, so cages, screws, and so forth. And we looked at the numbers, and we looked at the types of surgeries and what you can do currently with minimally invasive surgery. And we estimate that about 75% of all spinal surgeries that are being done today in North America can be done partially or completely with minimally invasive spine surgery and with high-tech technology. And it turns out that it's not only the simple cases, but there's really the sweet zone for minimally invasive spine surgery is kind of like in the middle. So it's not only the disc herniations and lumbar stenosis situations, which for us surgeons are relatively simple to treat. For a patient can be a terrible experience, of course, to suffer from this. But from a technical perspective, it's not that hard. But it turns out that with all this high-tech technology, I think the real benefit zone for minimally invasive spine surgery are those cases where you have to do a 1, 2, 3 level fusion because somebody has a deformity, they have scoliosis. And then if you go to the right, all the way to the right of that curve, where you have very, very significant deformity cases, those are cases that are really difficult to treat minimally invasive, where you really probably have to, currently, it's better to see somebody who is specialty trained in deformity surgery, and a lot of the surgery probably needs to be done open. But as Dr. McGrath mentioned, as high technology evolves and minimally invasive, the boundaries are going to be expanded. I think eventually everything will be done with less invasive surgery.
A lot of the things that we see at our comprehensive spine center, degenerative spine disease, we don't like to say disease anymore, but degenerative spine. At what point is spine surgery elective, where patients can wait, have some therapy, maybe have some procedures to kind of minimize their pain? And when does that turn into a more urgent situation where you guys recommend you need surgery to prevent further ongoing neurological damage? What are some of the symptoms that you say we need to get this done sooner than later?
Well, elective, I don't like that word in our field that much, because, I have patients all the time, like today, somebody asked me, well, maybe I should do the surgery after the summer break. If somebody asks me that question, that tells me that they're not really in pain. If somebody is really suffering from their spinal disease and they have nerve compression and spinal cord compression, they want the surgery tomorrow. And then, and it's elective because you're not risking like a neurological injury if you wait a few days or a few weeks. But it's not really elective what other surgeons maybe would consider like a plastic surgery, or you do it at the end of the year, or So I think that if ideally you want to have a situation where patients are really suffering, they really need this operation, of course, and those other patients are going to do really well. But if you're asking about red flags meaning that you have to push them as a surgeon to really make sure that they take care of this, bowel, cardiac whiner symptoms, bowel, bladder incontinence, saddle anesthesia, foot drop, significant neurological deficits and so forth.
So if someone out there has weakness, you would say that's not something you want to do after the summer. We should address that sooner to prevent permanent neurologic damage.
Yes, and that's something that also then here as a spine center, all of us together, that's the beauty of practicing together. So you can kind of develop a culture amongst spine practitioners where we all kind of evaluate things in a similar way, and also the urgency of certain pathologies, right? Because you may go, if you have like single practitioners, you may go somewhere and they don't really take things that seriously then sometimes, and they may wait and sit on somebody who has a foot drop, which in my opinion is a bad idea, because that's something that should probably be treated rather sooner than later with surgery.
Has the technology and minimally invasive approaches allowed you to treat patients now that maybe 15, 20 years ago you would not have treated with the conventional because of some risk factors, let's say osteoporosis, let's say age? What is the maximum age, if there is one, for spine surgery, and has MIS kind of put more people into a surgical category that previously would not be?
Yeah, Dr. McGrath, maybe he's with his endoscope. He can.
Yeah, thanks, Dr. Hartl. I think there are a lot of patients now that probably can get surgery that wouldn't have been candidates in the past, because with these techniques, we look at reliably being able to do surgery without nearly as much blood loss, for example. And that just means that it opens up the patient population a little bit wider than what it used to be. And I think we're also, as part of the minimally invasive philosophy, trying to do more and more surgery without doing a fusion necessarily, and trying to do things with just a decompression where we just take pressure off nerves without having to put in screws and rods and fuse bones together. And so that could be a good option with someone that has osteoporosis. And so all of these techniques, in their attempt to do less harm to the patient in the process of trying to treat them, I think that means that, yeah, they've opened up options to patients that previously probably weren't good surgical candidates.
Is there an upper limit on age of someone that you would operate on, or how old is too old?
I think it all comes down to the individual. I have just operated on an 88-year-old gentleman and did a fairly major surgery on him, decompressing his cervical spine, and he hopped up the day after surgery and was working with physical therapy and doing great. So I don't think that there's any such thing as a hard upper limit. I think it's a conversation that we need to have with the other doctors involved in a particular patient's care, cardiologists and primary care doctors, to make sure that it's safe. Because first and foremost, we want to make sure that you leave the operating room doing just as well as you were when you went in. But I don't think that there's a hard upper limit. I think it totally depends on the health of the person in question. But for sure, I think that the age limit and the age at which we're routinely doing surgery on people is getting higher over time.
One of the common conditions that we see a lot in the spine center, especially in the elder adults, and I'm talking 60s, 70s, 80s, is something called lumbar spinal stenosis. Basically, when the nerves in the spinal canal get a little tight and patients get back pain and leg pain, they can't walk as well as they used to. Can you kind of go through, without getting too technical, what is a typical MIS, minimally invasive surgical option for someone with stenosis? What are you doing there, and how quickly should those patients recover and feel some relief, Dr. Hartl?
Yeah, sure. I saw the question. It's a really good question. So lumbar stenosis means that, as you mentioned, that there's significant compression of the nerves in the lumbar and the lower part of the spine. And again, if patients fail non-operative treatment, which happens very commonly because there's nothing really that's going to take the pressure off the nerve other than mechanically removing that pressure, If patients fail, physical therapy, maybe an injection or so, then we frequently will recommend surgical treatment. And then it depends on the surgical technique. Like, there are 3 or 4 or 5 technically minimally invasive procedures that can be considered. We talked about Vertiflex before. That's an operation that can be considered for lumbar stenosis. It's not always the most effective one for the reasons that we mentioned. If somebody has 2 or 3 level lumbar spinal stenosis, the endoscope that Dr. McGrath mentioned may theoretically be a good option, but it just takes a really, really long time then to treat 2 or 3 levels. So then the time factor may play against that. For patients who have lumbar stenosis where you need to treat 2 or 3 levels, in my opinion, in my hands, in my experience, the tubular surgery is ideal. It takes about 30 minutes per level to treat that very efficiently with a minimally invasive approach under the microscope. And then you can add up. 1 level is 30 minutes, 2 levels is 1 hour, hour and a half. And these patients will frequently go home the same day. And even patients, we've treated patients as old as 96, 97 years old. If they are in a reasonable functional status before surgery, then you can treat those patients very safely with minimally invasive surgery. The age itself is not the barrier, it's really the functional status before surgery.
Orthopedics has, made a lot of strides in doing hip and knee replacements without putting patients to sleep completely. So they're doing a lot of regional anesthesia and local stuff. How has MIS moved towards doing different types of anesthesia for cases? Does every patient need to have general anesthesia and completely asleep, or can you do some regional treatments for spine surgery?
Yeah, there's a movement now to do awake spine surgery, and I think that is certainly an option. And Dr. McGrath maybe can talk about some of the endoscopic surgery that's being done awake. I think you have to be careful if you operate around nerves, because if the patient moves, if the patient is awake and they move and you're operating on a nerve, that's not necessarily good, because you could have an intraoperative problem where you could injure the nerve, for example. But there are certain procedures that are being done where you're a little bit further away from the nerves, like some spinal fusion surgeries now are being done with awake surgery. And I think that is certainly an option if done properly, but it requires the whole team to really work together, I know, Dr. McGrath, when you do your endoscopic procedures, you do those under general anesthesia or under local?
The vast majority of the time do it under general anesthesia. I have done it in patients that are awake, and I think because we do it under general anesthesia so frequently, the workflow is just so much smoother that I prefer to just do it that way, because it becomes routine and everyone knows the steps of the procedure through and through. I think there is a movement to start doing endoscopic surgeries awake. To be frank, most of the patients that I've talked to that have had awake surgery didn't enjoy it that much. And most of the patients I talk to are not interested in an awake surgery. So for me, it's something I'm watching and seeing how the movement develops. I'm keeping it on the back burner until it becomes a little bit more well understood. And we'll see if at some point it becomes something that the evidence bears out is better in some way for the patient. I'd certainly be willing to incorporate it into my practice a little bit more fully. But for now, I prefer to do everything asleep, and I think the vast majority of my patients prefer it the same way.
Yeah, I don't know why anybody would want to be awake during their spine surgery.
All right, we're kind of nearing the end of our time. I think I got to most of the questions of from the group. Really, really good questions from the audience. So thank you for that. I can attest to, like I mentioned earlier, some of the patients that we see in the spine center who have had surgery through an MIS approach. And most of them, like you said, go home the same day. They're recovering much faster because, in my opinion, the most important thing is to decompress the nerve and then also protect the muscles in the back. And through these MIS approaches, you don't cut muscles. So you just spare them and you divide them nicely. And patients can really do well. Any closing remarks for the group regarding MIS or anything, any common questions you get from patients that you see in the clinic?
No, doctors, I just want to mention, because we talked a lot about surgery, but especially for minimally invasive spine surgery, I just want to mention that obviously it's not only the surgical part, it's also the anesthesia, the pre, the peri, the post-operative management of these patients. And we've spent in the hospital, we spent considerable amount of time and energy and meetings and effort to maximize really our ability to eliminate pain before, during, and after surgery. And, we've implemented protocols, Dr. Verk, who's one of our partners, Dr. Hussein, several of the anesthesiologists really spend a lot of time implementing protocols that allow us to treat patients before and during and after surgeries with specific protocols that minimize the experience of pain. And just now, a few weeks ago, we started an initiative where almost every patient who has lumbar spine surgery, the anesthesiologist performs blocks, like nerve blocks in the operating room. And that seems to work really, really well in eliminating post-operative pain also, and really speeding up the process for these patients to recover. So it's not only technology, it's not only the surgical part, but it's really the team effort of the whole perioperative environment that works together to smoothen the experience for patients and make the whole experience more pleasant,
Fantastic.
And then obviously we're combining the spine programs between Columbia and Cornell, and that actually also has resulted in the exchange of a lot of know-how and information that's extremely helpful. Under Ox Spine, we're really growing as a community of spine practitioners, and that's extremely helpful for every type of spine surgery that we do.
I completely agree with you in terms of the comprehensive nature of what we're doing here at the Center for Comprehensive Spine Care and Ox Spine. Even in your book, as a spine surgeon, you talk a lot about diagnosis. You need to know what you're doing first before you go in there. You might have the best technique and the best technology. If you don't know why you're operating and what you're operating on, you're not going to have a great outcome. So certainly I applaud your interest and passion regarding the non-operative treatments. Anything from you, Dr. McGrath? Any closing remarks and things that you hear from patients commonly?
I was just going to say the same thing you just said. It makes doing minimally invasive surgery so much easier if we have partners like you and the neurologists and the pain medicine doctors at the Comprehensive Spine Center that can help to, over time, narrow down exactly what the specific problem is that needs to be treated. And that process of finding out just exactly what is causing pain is ultimately what is the best guarantor of success in doing a minimally invasive spine surgery. So I'm glad that you mentioned that. And I'm just very grateful to be a part of the Spine Center and to be able to work with colleagues like you and Dr. Hartl and to take care of such great patients. So.
And Dr. Verk, he's still with us, of course, fortunately. It's just that he's operating on Wednesdays, and that's why he never makes it to our Spine Time webinar. And we've got to try to get him more involved here.
All right, great. Well, thank you, Dr. Hartl. Thank you, Dr. McGrath, for really enlightening me and the group on some of the newest and latest technologies in minimally invasive spine surgery. Thank you out to the group. Really, it means a lot to us for you guys to spend time with us on a Wednesday evening, learning about our center, asking us really, really good questions. It's a pleasure for us to educate the group, and we learn from you just as much as you learn from us. So thank you, everyone. Stay tuned for the next Spine Time in a couple weeks. And remember, when it comes to your spine health, we've got your back here at Weill Cornell. Take care, everyone.
Thank you.
Thanks very much.